effort over the past couple of years, the Johannesburg CBD is the vital center of life for the many who study, work, and play there. And now, Clinics' First Day Hospital is right in the heart of the CBD to help sustain and enhance that life.
So Clinics has got the longest history in the country of providing a platform for black professionals in particular to be able to deliver care in the private sector. And our oldest hospital in the group, Dr. S.K. Matseke, has been doing this since 1985. And we have got a great experience, and we have got a large network of specialists across our facilities who are highly skilled in the different disciplines of medicine. We are really in a very good position to be able to make those skills and expertise available to the communities and the people who work and live in and around the Joburg CBD.
For more than 30 years, the Clinics Group has been striving to identify opportunities and meaningful ways to pay tribute to our founding fathers, who epitomized the concept of black excellence from the start. And it is in tribute to these visionaries that this hospital is named after the astute businessman and legal expert, Dr. G.M. Bike.
Dr. Bike was, to me, he was very, very special. From the home front, he was my father's best friend. And there would never be any important occasion happening at home without Dr. Bike being there. So he's always been there. At some stage in my life, I went through difficult times. He was there for me. You know, when I went through my difficult times, he was there to listen for me. When he went through his difficult times, when he had cancer, I was there to look after him. So I've got that special relationship with him. He's a community leader to me. He's my father to me. He's everything. The founding fathers, like him, is Dr. Bike, but actually he was a lawyer. Okay. Dr. Ntato Matlana was a doctor, but a businessman. Dr. Mukhesi was a doctor, visionary, a businessman as well. In whatever they did, they were quite diverse. Possibly, if you look into his contribution in law, you'll find that it's major. He was the first president of Black Lawyers Association. If you went into education, you will find that he also features in education. So they were a special breed of people that worked across their disciplines.
The Dr. G.M. Bike Day Hospital at 56 Van Willig Street in the heart of Joburg offers healthcare services in dentistry, dermatology, optometry, ophthalmology, physiotherapy, audiology, ear, nose and throat surgery, orthopedics, gynecology, pediatrics, maxillofacial surgery, as well as general elective surgery. The 36 beds in the state-of-the-art wards and private rooms provide a safe and comfortable space for patients to recover from same-day surgeries under expert supervision. The facility also offers doctor's suites for consultations with GPs and specialists for all who work and live in the city. For the convenience of all its patients, the Dr. G.M. Bike Day Hospital offers safe and secure parking and the use of a courtesy shuttle service for patients who need to be transported between other clinics' facilities.
You know, the business of clinics has always been to take care of the previously, historically underprivileged people. And we know that our city centers are full of such people. Our city centers are now full of people from outside our borders, from Africa, the north of where we are, and those people have not had that. They haven't had that the privilege of having the facility like the Clinics Day Hospital that is coming up now. So this is going to be a fantastic service for all of them, and we hope that the people will see the advantage of being serviced close to where they are. I think That's the whole idea of clinics, to serve people closest to where they live.
It is this ethos of excellence that provides a haven of healthcare for the denizens of Africa's busiest city. The Dr. G.M. Day Hospital at 56 Van Willig Street in the heart of Jozi is open to all every day of the week from 7 a.m. to 5 p.m. and welcomes all medical aids. And it serves as a fitting memorial to a remarkable man who dedicated his life to excellence.
Good evening, colleagues, and welcome once more to our weekly webinar hosted by Clinics Health Group. And we're excited to make contact with you every week as we share information about what happens in the healthcare industry and topical subjects that we bring to you with the help of friends and colleagues who are part of the teaching hospitals, private health sector, public and private, and everywhere, different disciplines, medical practitioners, specialists from the allied health disciplines. And we are glad that and once more we are able to bring this to you this evening to broaden our knowledge of how to manage cases that are presented before us at our various working sites, both in the public and the private sector, both as a specialist level and primary healthcare level or GPs. We're excited that we're welcoming in people coming from all walks of life, every part of the country. We've got colleagues coming all the way from George, and welcome to you, people from Soweto, Cape Town, people from anywhere where it's possible for you to connect. We just want to welcome you. And so this evening, we just want to request that, as usual, when you log in, please make sure that you mute yourself, switch off the video so to enhance the quality of sound and pictures that we are able to present during the course of the webinar. Note that also these webinars are CPD accredited, and all of our presentations are now available on YouTube. We are now live on YouTube. And so at the end of the presentations, if you want to review the presentations, you're quite welcome to link, go and join up, follow the link that we shall be presenting to you at the end of the webinar the following day. So we're excited to welcome Professor Carol-Ann Benn to this webinar, who will be speaking to us on a subject that she loves the most, breast management. And the topic for this evening is managing breast cancer and breast concerns, what we learned in the SARS CoV-2 pandemic. And Professor Carol-Ann Benn is a specialist surgeon, qualified from Wits University, has got a fellowship in the College of South Africa Surgeons, also a diploma in primary emergency care. She's currently based at Helen Joseph Breast Center and also Netcare Park Hospital, where she established the Breast Health Foundation early on, together with Netcare in 2001. And she also is a lecturer at Wits University. And she's passionate about what she do, and she makes sure that she provides care to both the public and the private sector, regardless of their income, and provides well standard care for all patients, as I said, both in public and the private sector. She's well published and has given many presentations locally and abroad. And so it's a great pleasure to welcome a dear friend, colleague, Professor Carol-Ann Benn. Thank you, Prof. Welcome. We are here to listen to you. You can unmute yourself. You're still muted.
I'm going to unmute myself, and hopefully Dominic's going to put on my presentation, or someone with IT skills are. I have to say that advert was spectacular. And if you need my help in any way with that clinic, I always say setting up breast clinics is not difficult. It takes SOPs, and I'm happy to do even smaller little YouTube things for you guys. The mainstay is managing things from a general practice point of view, and it's critically important. I'm just waiting to see how someone with techno sets me up here. I'm checking out someone's screen, so I'm sure they're going to sort it out. But what is so important is it's so easy to set up sensible breast health clinics. So I just had a lady who's flown in to see me from I want to say East London, who has a certain type of breast cancer, and what they offered her was they offered her straight away. The surgeon said he's going to do needles in his rooms, which is completely wrong. It takes a simple ultrasound and a needle biopsy. So second time they got it right. Thank God they didn't cut it out. And now we're going to tailor her treatment so she can have it there. Okay. But what we've learned in the SARS-CoV-2 pandemic, I think, is amazing. The fact that we can have hybrid talks like this is spectacular, because I still have patients waiting for me to see. It means we can communicate, we can talk, we can record it. People can play it at their own time. And it's the concept of hybrid is, I think, one of the spectacular things that's come out of the last 2.5 years. So have we made things better? Well, everyone looks at it and thinks we've made things worse, because in terms of when they look at jobs, when they look at every aspect, access to health, etc. But I do think that the last 2.5 years have taught us some very important concepts that we can learn from and apply to healthcare. And I'm going to use my little field of breast and women's health and cancer as an example. So a long time ago, okay, like when we talk about BC and talk about dinosaurs, well, I want to tell you, I think that the future is that surgeons are going to become like Tyrannosaurus Rex. Okay, not all bleedy and kill everything, but a little bit like dinosaurs extinct. I think there are many ways that we did medicine before COVID that we are completely not going to do now post-COVID. So another term for BC is before chemo, and surgeons were king, and people like Halstead, etc. We really had this concept that we could, anything we could cut out or take off was gold standard. So surgery for breast cancer was gold standard, and it was radical and big surgery involving taking out the pec muscle, the glands, etc. So in 1952, for the first time, the guys started to realize that these particularly big cancers and the certain type of cancer called an inflammatory cancer, which presents as a red, hot, inflamed breast and is often a missed cancer, actually no, they would cut it out, and before you knew it, the cancer would come back through the skin all the way around the chest wall. It's called cancer en cuirasse. And the surgeons realized this, so they used this to say, hold on a minute, actually, what we need to do is we can't treat these cancers because they come back too quickly. We're going to send them to our little nerdy medical colleagues who were the actually the physicians at the time. And there wasn't really a field of oncology. So oncology at that stage, if you think about it, post 1945, Eva Peron was treated with mustard gas for her cervical cancer, and we didn't really have many drugs. So they took 5 drugs and they put them together. And this is why the background of oncology is always apologetic around side effects. So when you go and see a cardiologist, the cardiologist says to you, ma'am, your blood pressure is too high, your cholesterol's too high. If you don't take statins and you don't take blood pressure medicine, you are going to have a heart attack or a stroke and die. It's clear. No one turns around and goes, the side effect of the statins are A, B, C, D, E, and maybe the side effects of the hypertensive drugs are A, B, C. When it comes to oncology, because the entire background of the field was drugs versus death, people would say, right, you've been sent to us from the surgeons, you're going to die of this cancer. What we're going to do is give you a cocktail of only 5 drugs, including steroid at the moment. And actually, the side effects are appalling, but your options is death or side effects of the medication. And guess what? 50% of these patients, in fact, 80% of them with advanced breast cancer had a response, and 50% of them had a significant response that had impacted on their survival. So suddenly we realized if we could cure cancers if we found the right drug combinations, and we can keep if we can keep patients alive during these highly aggressive regimes, we can have lower burdens and treat lower burden disease, which means we move from a radical mastectomy to suddenly in the 60s and the 70s saying, hold on a minute, let's shrink cancers down and let's look at other ways, breast conservation. And this was pushed by the women's movements. Why do I have to take my breast off? So that actually now today you'll see in one of the later slides that breast saving and radiation has a better survival than mastectomy. So now we have a new BC. We have a before COVID, okay? And what's happened after the pandemic. So we all have this concept that before COVID, we used to see early stage breast cancers and people would screen, and COVID has resulted in a high presentation of locally advanced breast cancers. Now, truth be told, a locally advanced breast cancer doesn't arrive in 18 months. So this is a lady who was seen before COVID, and she went the route of 2 different alternatives, before and herbs and etc., before she decided to come see us. And on, again, like I mentioned, with the dawning of the age of oncology, with the right chemo combinations, we shrank this cancer down so she could actually have a breast saving operation. So when you see people with locally advanced cancers, the question shouldn't really be, right, delay to presentation. The question is, why are people coming in later? And part of the reason, I believe, is the hostility of our hospital environment. And that's why I'm very fascinated in that advert and that clinic. And I would very much like to tie in and see if any way we can help. And it's really a plea and a call out to general practitioners in different parts of the country that we can help you set up small, safe systems for patients. Because it's difficult for people to catch 4 taxis and come in and being told that there's no service on that day, okay? Or actually think that really everyone's going to die on the treatment, or my cousin died when they went into Helen Joseph Hospital, therefore I'm not going there. Or as we well know, there's such problems with delays to oncology treatment at, I have to shout out to Prof. Demetrio, who's turned it around amazingly. It's a 1-week waiting list for oncology, but huge delays to radiation, which makes our life is a domini health conversation null and void when you see what's happening on an oncology thing. So there's opportunity here, because what we do is we were all taught at medical school about risk factors for breast cancer, but breast cancer is neither ageist, racist, nor sexist. We see, and I saw at Helen Joseph, my clinic today, at least 5 girls under the age of 27 with lazy luminal A cancers. So these are cancers that have been sitting there for at least 5 years. So we have to ask the questions about, and a lot of them say, well, I went to a clinic and they said I didn't have any risk factors. Yes, I may have been female, but I'm too young, and I have no family history of breast cancer. But when we look at risk factors, really, like I said, neither ageist, racist, nor sexist. So surely you can get cancers as you get older and more frequently. So 1 in 4 people at 70 have a cancer, but young people can get cancer too, okay? The genetics is not as simple as BRCA genetics. Less than 10% of people have BRCA, and often we have a combination, like a roll of a dice. Obviously, what we want to encourage exercise, decrease in alcohol, and keeping your BMI low. So before COVID, we did community-based screening and breast health awareness. As soon as we had lockdowns, what we did was we converted our navigators, myself, everyone, suddenly onto a virtual platform. That's why I love what Dr. Billis says about on YouTube and everything, and happy to help out. Small little bites, that you can listen to in the car about how to manage breast pain and what to do about breast meds. Those are critically important and easy things. I've started doing them as well around things that, I'm sorry, I'm just seeing someone in the background. I can hear a lot of noise. So things that that I can learn on. So what is important is we moved to a virtual platform. Also from a Breast Health Foundation, information like if you need re-scripting, just contact in and we can sort things out virtually. Because I think Dr. Biller is well aware, I presented a paper once where I looked at cost of tamoxifen from a cancer drug, which is 14 Rand per month on tender at government hospitals, and patients have to come in once a month to fetch their medication. And we see people over 80 coming in for their medication. And the problem is that these people are having to catch, can you hear me? Yeah, all good. These people have to often catch 2 taxis, and the cost for them to open a file is way more than the cost of the medication. So by virtual scripting, by working out, by going to bed, and this is where the business people need to get involved, possibly with pharmacies, etc., because these are cheap medicines. And unfortunately, I think it's part of that old TB focal point where we wanted to watch people take their medicine. I always maintain that my government patients are way, way more compliant than my private patients because they haven't Google Docs everything. So here we are in the present, and what we've always done is translational radiology meetings. I mean, we do it at Helen Joseph, we do it here, where we look the radiologist and the surgeon, and now we do it digitally. So it's more than looking at a report that says this is a fibroadenoma. By visualizing it with multiple doctors or radiologists, you can say, hold on a minute, this doesn't look like a fibroadenoma, it looks like a triple negative breast cancer. Then working out why we can do specialist ultrasounds, check the lymph nodes. Maybe we need more careful use of MRIs, okay? So MRIs are hugely expensive, okay? And I don't think we are going to look at all the data and the outcomes compared to surgery in the units. And I think that possibly sometimes they're overused, and maybe there are other ways that we can look at things to make sure we're not missing things in the breast. We need to audit and self-audit. I'm fascinated. Post-SARS CoV-2, I see more biopsies that are negative, and the cost of a radiology-guided biopsy is anything from 14 to 20,000 Rand, and then the patients have that with the pathology. My biggest bugbear, and I saw a lady today at Helen Joseph, well known, is when people come to me at Helen Joseph with a private mammogram and a private core biopsy with none of the special stains, and I always ask them, what did this cost you? North of 5,000 Rand, okay? And then referred into the clinic. Shame, that 5,000 Rand could have been well used for anything from education to a holiday to food, okay? Where they can get equivalent care at Helen Joseph. So we need audit, we need accredited CPR, clinical path and radiology review. We need to understand what biopsies. So again, I think Dr. Villa knows I've got a couple of presentations at First in the World from Helen Joseph. We use magnetic markers over a duration period of time.
All right.
Okay. And the biopsies we place them at the start of chemotherapy, and they're still magnetized at the end of chemotherapy. So you're not having multiple markers and multiple costs to patients, but when you give them their treatment, you're shrinking down their cancers. So we've got to understand the reason why we need radiology navigators. We need to understand funding structures. We need to understand that people are not going for emergency surgical biopsies, okay? This actually happened less in the pandemic because people couldn't access hospitals. Most surgeons didn't do this, where the radiologist says a palpable lump referred to a surgeon. Now, that is just ancestral and not right, okay? So if the patient is a palpable lump, the radiologist must have a way of organizing a core needle biopsy for the patient and work out the cost effective of it, and the patients must know what the cost is. So these are surgical biopsies to pick up cancers, which actually jeopardize someone's outcome. The most important thing where we've learned over the last 10 years, and it's been honed in the last 2 years, is the importance of the chef in the oncology equation is the pathologist. Previously used to diagnose a breast cancer, now prognostically tells us what type of cancer it is. But as we do things such as gene sequencing and everything, we can actually predict which treatment and what is the response to treatment. Historically at medical school, we all learned about TNM, size, the Hulk, more scary than who are these guys here? I've got to work out Iron Man or Thor or something. But actually, it's not about size, it's about personality, which determines how cancers kill. So really, once we could start looking at breast cancers, and this changed in 2011, and subclassify them into luminal A's, which are very lazy. I just saw a little old lady who's got a tiny luminal A cancer and quite a lot of medical comorbidities, and she's going to go on to an endocrine treatment. And I'm going to show you something sexy at the end. She may not even need surgery. Okay. We've got new classifications for different cancers, and we can even genetically profile cancers to work out if they really need chemo or not, even in people where the cancer's in the gland. So our enlightenment has come that cancers are different. We individualizing patients' care. The area of recipes and regurgitating formulas is over. It's personalized medicine, and COVID-19 pandemic has shown us this particularly more. What I've also liked about it is because doctors weren't working and patients couldn't come in, suddenly the foot, the shoe changes to the other foot. Suddenly doctors are needing to realize, okay, so I mean, I frontlined and I opened up my entire Moore Park unit to my government patients, and until we could clear up that people felt safe to go to the Helen Joseph Clinic, and then we had to put chairs outside and social distancing, and it worked really, really well. But suddenly doctors are realizing, a lot of doctors closed practice, and a lot of doctors who weren't frontlining suddenly realized, eek, no one's coming in. So the concept of telemedicine, calling people, contacting into people, and that generated a change for a more service profession, which I think we needed. So if biology dictates and cancer can't kill, we need to understand the extent of disease. So we local regionally marking, I've mentioned mag seeds prior to treatment. Our systemic treatments today is chemotherapy, endocrine, targets, immune, and radiation. Our chemotherapy over SARS-CoV-2 became more personalized, including some even oral chemotherapy, and what is going to change in the future, I think, home-based oncology, outpatient-based, okay, safer. More endocrine treatment. We took more patients and we put them on endocrine treatment before operating on them, both in government and in private. And guess what? The patients were fine. Their cancers didn't grow. We realized we didn't have to rush in. So, okay. So basically what moved straight away as soon as we went into pandemic, and I thank Dominic, he's sorted out all the slides here, and he's really good and useful if you need him from MDMs and medical IT, and understanding an important aspect of it, which is the security, cybersecurity around it, is we could move everything digital. And the value of digital is it means it's like this, it's recorded. So you can check the radiology, check the pathology, check what the commentary is. I'm sure he has to delete a lot of the funny medical, doctors sometimes can say things they might not need to necessarily say. But you can take it and you can have it virtually as well as call in or dial in people. So we now have people coming in from George Oncology and from, I think it's Clarksdorp, if I'm right. And I think Dom's in the process of working out how to set up regional virtual MDT so that people who are not sitting in Johannesburg can at least have access to what is current gold standard, because that protects patients. So you discuss all the patients, and this really is how we run our accredited unit, and I really run the HJH unit identically, and how we work out patient treatment pathways, and you're welcome to these slides, and these things are being presented, okay, internationally. I think the one just got an award, okay. So yeah, these are ones that Dom has really been involved in: digital, multidisciplinary, tangible benefits, and we looked at the number of patients seen. So whereas most units shut down and saw less during SARS-CoV-2, we actually saw more. Did Dom remind me on our patient numbers increased?
680 to 745.
From 450 to 680 to 745, rapidly. Now, this is during lockdowns and everything, because people suddenly realize that they have an option of how they can come in. So staging and risk assessment also changed. So the concept of everyone is having hundreds of tests to work out what's going on. Suddenly we realize we are only testing people if they're symptomatic. It's once off. We're not just doing random bloods and mammogram and ultrasound changes to yearly and not 6 monthly. So we had a more holistic approach. primary oncology change, where we could give oral chemotherapy. We had better cosmesis. In fact, we had a couple of patients that we gave chemo to, and then we froze their cancers, and we didn't have this rush to emergency mastectomies and surgical biopsies, and particularly also because people couldn't access the hospitals. So we had personalized oncology treatments, TAC for trip negs, targets for HER2. We've now got CDK4 and 6 inhibitors for the big luminal A's. I'd love to see that in government, which is an oral tablet. So basically in more primary endocrine treatment. So we changed our treatment. So we have new rules. We place mag seed markers up front. We document our tumor size, our extent of lymph node involvement, because that determines who needs radiation. Way more breast-saving surgery. And we changed if people didn't respond to treatment. In our HER2 positives, we now have dual therapies available, and more of these patients getting targets with a complete response to chemo and better long-term survival. So we have what's new in oncology. Okay. Oh, I see someone got a fail there. I think, what were the 2 exams I failed? My learner's license and my ballet. Okay, there we go. Okay, but everything else I OCD'd. Okay, right. Personalized oncology. So we've mentioned target therapies, tumor profiling. Now we're considering profiling on core biopsies, but currently we luminal A's and luminal B's. What we do is profile the tumor and see if people even need chemotherapy. We now do more ovarian protection by giving injections to protect the ovaries in young people. Okay, so less chemotherapy in metastatic cancer, more understanding the biology of metastatic cancer and treating on that. So we've changed our medical landscape. Okay, so some of it is partly due to lockdown and pandemic, such as telemedicine and a less is more patient approach, but some have actually been happening over a long period of time, 10 or 11 years. And really, I think what the pandemic allowed us to is, I don't want to say throw caution to the wind, but really what we did was we usually wait long-term for oncology trials and long-term for change, and we enforced more rapid change where we accepted data chains on less data and the concept of being more personalized. So biology, surgical caution, and definitely a big pull to navigation and survivorship, and particularly that from a digital point of view. So we had our virtual MDMs and our telemedicines. And again, if you need information in setting that up, you just contact in with Dom. That's his big thing. And social media, yes, the good, the bad, the ugly. Okay, I have no social media presence. Okay, but what we did is through things like Breast Health Foundation, we told patients that please wait outside for the breast clinic. If you need routine mammogram bookings, just you can contact in and we'll write your forms out for you and give you a date so we can virtual it. Scripting. Contact in as if you're worried about breast abscesses or pain. So it actually worked. So I think our systems in the clinic, look, I've lost my ward. It's still a COVID ICU. The place is a bit of a mess. Okay. But I'm really hoping, I mean, I don't have size 7 gloves but what I do know is that some things are better. So let's see, it's the face of medicine. Okay. And I think where medicine actually lost a lot of the battles around vaccination was that doctors, not the, and I hope I'm not offending anyone, the weird or wonderful ones who anti-vax, but doctors who understood the process didn't make themselves available to explain things to patients at taxi ranks, we didn't mobile out vaccines, we didn't explain the myths and the concerns about it's not going to change your cells and that. So we need to be clear that we have the right face of to give a social media presence. And I always honestly think as I get older, I've got a face for radio, but what we have to do is, I've got 5 youngsters involved in the Breast Health Foundation now who speak all the different languages. They are going to become the face of the Breast Health Foundation over the next 5 years. And I'm training them out because you've got to have succession plans. But these youngsters understand all the social media and the how-to, and if they can be groomed into what is correct, responsible social media, we can change the face of medical information and access to care. So we can educate and engage. So, all right. So I think that's important. General practice support patients. So we have more of that, and I'm happy to engage and interpersonal skills here. Okay. So today, we always knew that very few people needed a mastectomy: inflammatory cancers, multicentric, Paget's and lobulars, and some people with prostheses as by choice. But we did more BCTs, but this was expanded hugely during the pandemic with smaller surgeries, more parenchymal flaps. We realized more radiation. We did more radiation in theater. So it was really awesome to see the rapid changeover. So currently now at Helen Joseph, almost 60 to 70% of my patients are getting breast-saving surgery. We safely remove the cancer with a clear margin, and you obviously yield your blade carefully, and we take less glands. So the current data shows now, okay, from the SEER data, that breast conservation, okay, actually with radiation has a better survival than a mastectomy. So that is completely different to what we taught and learned at medical school. So change is the law of life. We need to responsibly re-educate research. And I think that the rules of medicine are not written in stone, but are going to change with every generation. And we have an opportunity, you know, it's a terrible thing to say, but wars, pandemics, etc., make us improve and look at how we're doing things. It would be nice to see if we had, that's why, again, I love that advert, if we had more people having hearts of giving and not hearts of taking, which we did see a lot in the pandemic, sadly. So, for example, when I look at my post-chemotherapy patients from 2016 to 20, so obviously it's pre-pandemic, etc., the whole world is going to less is more with surgery. And we just do a sentinel and say 2 nodes post-chemotherapy to take an average of 3 glands. We don't have lymphedema, and we've had no recurrences today. So we do lots and lots of breast reconstructions and smaller procedures. And because less access to prostheses, we do more Goldilocks, government and private. Obviously, I'm not saying everyone needs bilateral mastectomies, but really where what we can do is use our own slightly body fat below our breast to reconstruct our breast. So I mentioned that presentation that we just put in as an abstract, I think, on Tuesday night, on 960 something patients who didn't get full axillary dissection post chemo. And we know that the axillary dissection is a historic procedure. So more sentinel lymph nodes, we're happy to teach them. In patients who are node positive on ultrasound, we often start them on oncology, and basically we don't need to do axillary dissection. So these are how we do sentinels. We no longer even use isotope. We use something called magnetic tracer. And what we've also presented over the last couple of years is we're looking at we become tighter with how we do our surgeries and our immediate reconstruction with lower and lower complication rates, because obviously what we don't want is patients having long stay in hospital. So this is spectacular data. I mentioned earlier genetic profiling is the new kid in the block. And really what we do is profile cancer so we can work out exactly what treatment they need. And a lot of us know about the ONCOTYPE that shows that who doesn't need chemotherapy. And we looked at anyone with an ONCOTYPE score under 25 doesn't need chemotherapy. But the new data actually shows that we can, even in people who have got node positive disease, don't need chemotherapy. And that's the TailorX trial, which is done beautifully, that shows they do not derive benefit from chemotherapy if the glands are positive. Okay, here we go. Now, endocrine treatment. In the old days, we used to say young people, tamoxifen, old people, and aromatase inhibitor. Now we go, no, we can use both for either, and we use it with a GnRH to switch off from a pituitary level if we need to put a young person on AI. So obviously people have a uterus, we watch PV bleeding on tamoxifen, and patients with hysterectomies and Mirana's, just remember you don't know if they're menopausal or not, so you would give the GnRH. We use more and more short-term radiation, and that became the rising star over the last couple of years. where radiation indications have increased, 1 or more nodes. So I always say breast can serve almost anyone, because if there's even one gland with cancer, and they're going to need radiation anyway, so why are you taking the breast off and radiate on a flat chest wall? So, but what we've really seen is less radiation, 3 weeks radiation, intraoperative radiation. This slide always depresses me because it shows how most of the world have many machines and Africa doesn't. And this is where we need to use things like radiation in theater and change the face, because so many people need it, breast and cervical. So the future is, so we have at Mill Park, and I specifically got Netcare to buy it because it's mobile, because I can't wait. Then I can use it at Helen Joseph. This is a intraoperative radiation machine that's mobile that we can use, and we use it in theater. There's a nice picture, and not only has it been of value of killing the area around the cancer and avoiding external beam, but actually it shows that from an immune point of view, it might be benefit. And they're currently doing a worldwide study. It seems like the patients who had intraoperative radiation didn't get COVID and didn't ever have any hospital admissions even prior to vaccine. So they're working out what's the immune basis of it. So I think we have to look at things from a different dimension now post-COVID. So we've always known, but we never applied, that not all breast cancer patients required surgery. Okay, so this is an old 80-year-old and a young 80-year-old. Now what we've had access to is we have a cryoablation. And again, I'm hoping to get it at HJ. But what we do is we, under sonar guidance, freeze cancers. So we usually freeze the lazy luminal A cancers. And we've just put together, I think, an abstract of 40 for presentation. But during the COVID pandemic, we scaled that out, and the whole world did it, because when I was in Portugal in November last year, people were using it a lot more around lockdowns and high when hospitals were full, because it's an outpatient procedure and you can just freeze the cancer. But more than that, it seems that it even has an effect, again, an immune effect on distal metastases. Thing that I think is going to come into being is contrast enhanced mammography. Okay, obviously you've got to watch with contrast, and you've got to watch with safety and where you're doing it, but a cheaper version around MRI with good outcomes. So the move is, and I've had a couple of meetings this week, of breast imaging and AI, where we're going to require less doctor read and better analysis digitally, and I think that's where we're going to go. So that's deep learning. We've decreased time in theater by having radiology machines in theater, by putting markers in that we can quickly remove these mag seeds. So by decreasing time in theater and really highlighting that we've got quick and tight processes in, we also improve cancer outcomes, because the ERIS data shows that less time on table improves immunological recovery and less problems around cancer. So we use these magnetic seeds, both at Helen Joseph and at Mill Park, and with really beautiful outcomes. So I think what we know, and we've known before and we know now, is what's necessary in breast cancer, and it's been zoned around the pandemic. Diagnosis by core biopsy, not surgery, because people weren't accessing units, but we've known that all along. That's the gold standard. Understanding oncology is supreme. Multidisciplinary meetings, clinical radiology correlation, translational radiology, digital MDMs, immediate reconstruction, and understanding who needs radiation. What is new is biology trumping size, a less is more and a more personalized approach, as well as profiling, more indications for radiation, less for prosthetics, ERIS, and cryo. What is nasty is the burden of disease that we see in low middle income countries, but throughout the world. The shortage of clinicians. It saddens my heart how everyone is up offing and leaving the country. I'll just give a little word of warning. The grass is only greener because someone peed on it. Okay. So there's insufficient radiation machines. Okay. And the nice is that I think we have an opportunity for an African Renaissance from health education and technology aiding clinicians. And we really, as a group of South Africans, I think, really know how to practice Ubuntu and care. So women's health, okay, we have to work together. We've got to put breast with cervical and HIV. We've got to look at improving out and rolling out national health initiatives, and particularly when I hear about these clinics, very, very important. We need to make sure that navigators and counselors are acting as an umbrella for the patient, better digital infrastructure and administration, as well as community education. So the next is the future of survivorship. We've become more digital oncology teams, patients not accessing oncology units for their survivorship and their chronic medications. And we have a happier patient where they should be accessing their general practitioner. I'm going to run a 4-hour survivorship course. Dominic will record it, and we're happy to send it out to any GPs who want to, or doctors who want to be involved in oncology survivorship, lifelong care. So we have, I think, a rainbow nation of really good units, but there are lots of inequalities in private and government that we need to improve. So I'm going to always say, like I say, state of the nation, you need to care a lot, okay? So unless someone like you cares a whole awful lot, nothing is going to get better. It's not. That's the LORAX. So let's incorporate innovations, technology, and strive to effective, accessible, and better cultural patient care. So there's a quote from Francis of Assisi, and any questions from my side? Okay.
Oh, thank you very much, Prof. Benn, for this very exciting, I think a detailed presentation of your talk, and I think you're using quite a lot of animation, and people are quite happy with the presentation. I've had a request to say, this lady is quite good, splendid. Can we have the presentation sent through? I believe you've indicated that you will be able to share this presentation, though they will be available on YouTube, as you said. Okay, just one thing that I just want to check. I can't read my messages. I don't know what has happened. I'm unable to read chats that have been posted. You will help me if you are able to read from your side. But this, what I wanted to find out, with YouTube, you said you're quite prepared to assist in posting short videos on YouTube.
Yeah.
What comes to mind is perhaps something like a short clip that does breast examination that any practitioner can have in their practice and maybe able to share with their patients. As you say, pre-COVID and post-COVID, the world has changed, and access to information has been enhanced, and that we can share that with patients in the rooms.
Absolutely. So how to do a breast examination, things such as management of breast pain, breast masses, nipple discharge, because really most breast problem management should be in the hands of the general practitioner, and with an idea of where to refer into what, and aware of what costs are going to affect patient. So not everyone needs to access into a breast specialist, but you need to be able to access into the breast specialist if you need access. So lots of people often just contact me and say, we just need your advice. I have a very nice general surgeon down in the Eastern Cape who regularly sends me stuff from one of the government hospitals to say, listen, this is this thing. I want to do a breast saving operation, and he just sent it to me on a WhatsApp, and I draw for him how, and if necessary, we send him a little video and he does it there. And what an amazing way to communicate and ensure that people get really good care throughout the country and extend it into Africa even.
Yeah. And then how do you manage the balance between public, private? And you said during the time of the lockdowns, most patients at Helen Joseph could not access care, but you're able to see them at Malpark. Yeah.
So what we really do is just opened it up as a completely free unit, no cost, no anything, etc. Because what people went through a phase of fear to access, particularly units where they were worried about things such as cleanliness and COVID, where am I going to get it, etc. So as soon as we were over that, we could move back in and sort out our clinic at Helen Joseph. I mean, we never closed once, okay. But the Beta Digital, I have accessed Dom here and the guys at Mill Park. So they ran this continually with, obviously my cell went out, and my cell is always available to anyone, but WhatsApp and information and handing out scripts, and I've got an abscess, because I think people felt less intimidated. I actually moved my my Millpark unit that's down at the bottom. I've taken over the whole of the Sanssouci Hotel. Okay, so again, it's not in the hospital, and that was a really nice COVID SARS-CoV-2 project. But for the first aspects of the lockdown, where I was going to Helen Joseph and to here, people were scared to access hospitals, and where they were worried that, you know, oh, I'll pick up COVID on a chair or on a toilet or on or walking down a corridor. So having systems where they felt more secure was easier for the patient. As soon as we went on to level 4 and level 3, we moved everything back. But for the whole 2 years, until we were completely out of whatever that thing is, people could access straight away into the Millpark unit as well. Okay, but we have no outstanding cancer patients at Helen Joseph. We've worked it absolutely throughout. So I'm very, very proud that we've managed to offer full service throughout.
Okay. Would you say that what you said as pre-COVID and post-COVID, in terms of the prevalence or maybe the severity of disease, has there been any change in what you see patients present with breast cancer, pre-COVID and post-COVID, and also if there any discernible impact of COVID on breast disease?
Okay, so that's a lovely question. So basically, we've currently got 2 studies going, one at Helen Joseph and one at Millpark, to see if there's a difference. Okay, what we saw more cancer, not less cancer. Okay, which is unusual, because most places where they had big lockdowns saw less cancer. I don't know, Dom, if you've got staging over the last 2019, 2021. No.
Not accurate.
Okay, not, he says not accurate. He's capturing it, the 21 at the moment. So in other words, when we look at stage of presentation, who presented, so we're putting together per month, how many people presented with advanced disease or non-advanced disease, but I don't think it's made a significant difference because people were able to access the units. So remember, currently at Helen Joseph, 60% of my patients present with advanced cancer. What I did see is, from a profile personality type, people who weren't going to come in, and they'd blame COVID. Okay. People who were going to come in would come in even with the fear for treatment because they were scared of what they were finding in their breast. What COVID affected, I think we had to watch. So it was interesting in the unit, we didn't, and lose is such a euphemism, we didn't have patients die. A lot of our oncology patients from COVID, we had a lot of people phoning in wanting information to say, can they not go to work because they're immunocompromised because they had cancer? And we had to do a lot of teaching around that, because having had a cancer, and as long as an encouraging vaccination. So I had a little old lady in the clinic last week who wanted a letter to say she wants to go visit someone in another country and she's not vaccinated. Can I give it to her? Because she's got cancer. I said, no, you go vaccinate. So basically that was interesting for me. I had cancer 5 years ago. Please may I not go to work. So I think we did a lot wrong medically about not allaying fears, which we all had, me, you, and everyone, around the SARS-CoV-2 pandemic for patients.
Okay. Now you mentioned vaccination. There's a drive to make sure that all cancer patients they get vaccinated now in the first dose, second dose, and the booster, and maybe even the fourth dose. What do you find? Are all your patients, majority of them, vaccinated, and what do you do to encourage them to get the vaccine?
So at both the clinics, we ask everyone, are you vaccinated or not? And if people are not vaccinated, we get them counseled. So I'm going to hopefully not offend anyone, but I find you can almost encourage anyone who's got medical concerns around vaccination to get vaccinated. The groups that you can't change their mind is if they're vehement anti-vaxxers about everything. But I always say, if you've vaccinated against chickenpox, what is your problem? So once you educate, so Charlotte and myself did vaccine videos, because he knows we spoke about a vaccine is like your body getting gym. People with significant religious end time convictions around vaccines, I couldn't convince them to vaccinate. So these are important studies that we have to put together. But almost anyone, once you explain to them value benefit, you could convince them to vaccinate. So I think there's a huge need medically for mobile vaccine units, because people, I don't think our stats around COVID are accurate, because what happens is if you're sitting somewhere, I won't even get into lockdown and small shack living, etc. But if you're living in a place and you don't have a lot of funding, people don't access government units unless you're really, really sick. So if you have a little snot and a cold, you're not going to access. That's the first thing. The second thing is, if you don't have a lot of money, are you going to go and stand in a vaccine center for a vaccine trial? So we need to take things to people, whether it's our medical education, our cancer information, all aspects. And I would have hoped that this last 2 years around the pandemic has made doctors realize how important it is for us to educate ourselves, but educate other people and our patients in a horizontal way and not a vertical way. So more communication.
Yeah. Okay, I don't see more questions posted. It's quite unusual. If there's anybody who's got a question, please do post on the chat line or unmute yourself. Just last comment for myself. You mentioned that in terms of surgical intervention and the theater time, that the longer the patient is on the table, there's some challenges that it affects the immunology, and the shorter period of time does better immunology and better recovery. And any indication why is that so, or it's just a incidental finding?
No, so I actually presented a paper about 5 years ago in Dubai on ERIS, enhanced recovery after surgery, and I'm trying to encourage a couple of the anesthetists to do MEDs on it. We definitely know from the opioid drugs, knock out immune system. We know that that operations do anyway. So what that does is in a way, if you look at circulating tumor cells, etc., it affects the cancer's ability from a spread point of view. So we want short operating times, quick surgeries, breast savings, not a lot of blood loss. And there's more and more data on this topic. It's a fascinating topic on the immune system and cancer. So there are so many variable factors. So we think anti-inflammatories are good, not bad, but opioids, bad, not good. And I don't think we have a comprehensive view, because there are multiple factors coming into play, but there's definitely anesthetic, surgery, etc., not all good.
Yeah, there's an interesting comment here by Dr. Sabete Dineo. Thank you for an interesting and deep presentation. I loved the part about the role of deep learning in transformation patient care. Clinicians should really consider collaborating with colleagues in the field of computer science and conduct research using machine learning. In my center at Charlotte, Johannesburg, deep learning predicted mortality in heart failure patients with an accuracy of 86%. Suppose this is actually Prof. Tabet, isn't it? They know it's just maybe Prof, you want to comment? It must be the cardiologist at Charlotte, yeah.
But this is so important. So I'm happy for people to comment in, but I think that we are underutilizing what we have accessed and forced on ourselves in the last 2 years.
Yeah. Prof. Tabet says, thank you for this comment. And I think it's fascinating just with the advent of AI that we should all be looking into that and see how we improve patient care. Any last comments for, say, people in the primary healthcare centers who see patients present breast disease? Any comment, advice that you'd give to colleagues who blocked in now?
So remember, cancer can happen to anyone, breast cancer. I think this concept of virtual, digital, and deep learning is about us collaborating. So if you've got concerns, it is not hard to set up small breast clinics, to utilize digital and virtual to communicate in with specialists in the field. I mean, I know lots about breast, but nothing about anything else. So this is an opportunity for us. And then we can start using computer-based deep learning to work out how we improve our systems. So what a privilege to be part of this forum. And I just thank you again.
Yeah, no, it's a pleasure. Always welcome.
Yeah.
We'll always call upon you to give presentations. I'm going to ask Dr. John Mohopa, who's our Group Occupational Health Manager at Clinics Health Group, just to do a vote of thanks.
Yeah.
Yes, Doc, you are, yeah, sure.
Good morning, Dr. Bila, and good evening, Dr. Bila, and good evening to Prof. Thank you very much for a very informative presentation. On behalf of Clinics Health Group, our group CEO, Dr. Matseke, the executive committee, Dr. Bila, who is the mainstay of organizing, these talks, and the marketing team, would like to, thank you dearly. For me, as a general practitioner, I'm in the occupational health and medicine space. It's quite interesting to see how, the management of, breast cancer has evolved, since the days of tamoxifen and the things we learned about back in the days. A lot of things have evolved, but we thank you very much for this presentation. And I would equally like to thank, all the participants, that came in, all the, people that tuned in into this platform. And we urge, for more, registration on this platform to grow, this particular presentations going forward. And yeah, with those few words, I'd like to say thank you very much. And thank you, Dr. Bila.
Thank you.
Thank you very much, Dr. Mohopa, and thanks a lot, Professor Ben. It's been quite an exciting evening. Everyone has been happy about what you've seen. And we'll call upon you, as I said, once more in the future. And we continue next week, colleagues, and we have Professor Joe Varela will be doing the presentation. Please do log in. We'll be sending out the invitations for the next session. Thank you very much and have a good evening.